Welcome everyone this evening to our regular webinar series for the Australian New Zealand Skull-Base Society. We're very fortunate tonight to have a number of experts that are going to talk to us on management of chondroid lesions of the skull base, as well as chordoma. I'll introduce them briefly. So the first speaker will be Mitesh Gandhi. He's a skull-base radiologist extraordinaire here in Queensland. He was trained in London, but he has done fellowships in cross-sectional imaging, and he's the go-to man for us with anything related to skull base, head and neck. He's going to talk to us initially about the radiological features that we would expect to see in these lesions, and he's going to be followed by Professor Shaan Raza, who we're grateful for him joining us so early in the morning from MD Anderson. He's a skull-based neurosurgeon there, and he's got extensive experience in dealing with these lesions, and I very much thank him for his time. And then finally, Associate Professor Matthew Foote, who's a long-standing colleague of mine and a radiation oncology specialist who's got an interest in stereotactic radiation, quite considerable experience in dealing with both malignant, benign and vascular lesions of the skull and skull base. Thank you very much, Matthew, for giving up your time tonight. Mitesh, do you want to start us off, please, and talk to us about the radiology?
So thank you, James, for asking me to talk about chordomas and chondrosarcomas radiology. I'm going to divide the talk into two parts. I'm going to give the first part, and our fellow from England, Portsmouth, Jeremy Neal, is going to do the second part. It's not going to be a long talk, but we'll spend 7 or 8 minutes each. So we'll start off with, I'm going to talk about imaging techniques and imaging characteristics. And Jeremy is going to talk a bit about the differential diagnosis. I assume you can all hear me?
Yeah, all good, Mitesh.
Okay. So we start off with CT, and CT and MRI are complementary for every skull-based problem that we look at. We use thin section CT. We go down to 0.4 millimeters thick slices, which are acquired volumetrically, so we can reformat in 3 planes. And the purpose of CT is to look at the pattern of bone change around the lesion, which tells you how aggressive it is. It also looks at matrix mineralization, which gives you a clue as to what the lesion might be. And the site of origin of a lesion may help differentiate chordomas from chondrosarcomas, and that's the main feature we use for differentiation. And it provides a surgical and an endoscopic roadmap, which is easier to use than MRI. So chondrosarcomas start off from cartilage rests, which can be in the spheno-occipital synchondrosis, but we've never seen a midline one yet. But most of our cases have come from the petroclival fissure. So you can see that on the axial and on the coronal study there. And on the contralateral side, you've got a lytic lesion, which is expansile and eroding the medial petrous ridge. And there's a matrix calcification within the lesion, characteristic of a chondroid type of tumor. So this is another chondrosarcoma, which is a bit larger and eroding into the middle ear. It's a lytic lesion. It's got some matrix calcification, producing expansile change. Whereas the chordomas we've seen always seem to arise from somewhere near the midline. So the literature tells us they come from the spheno-occipital synchondrosis. But most of the cases we've trawled through in the last fortnight in our database have come around the dorsum celli and high up in the clivus. We've had one case that's inferiorly in the clivus, which I'll show you later. And they produce aggressive lytic change. So you do see ossification within the lesion, but that's ossification produced by destruction of bone, producing aggressive splintering rather than matrix calcification. This is a slightly atypical lesion at the top of the clivus, producing reactive osteoblastic change in the bone around the lesion. There's a large soft tissue mass, which you can't see, but part of the lesion is quite low grade with sclerotic margins in the midline producing expansion. This is another type of chordoma we've seen, again, lytic change with a soft tissue mass, which you can just make out, and some sclerosis in the underlying bone. And this is the slightly atypical one at the lower end of the clivus producing lytic change. This is a chordoma that's just off midline, and it's almost onto the petroclival fissure, and we had some difficulty with this. It's producing scalloping rather than lytic change. Turned out to be a bit of both, a chondroid chordoma. Soft tissue windows on CT don't really help, but chondrosarcomas tend to be low in density, whereas chordomas tend to be of soft tissue density or slightly higher. So the role of MRI is to look at the soft tissue extent of the tumor. You've seen the bony extent on the CT. You're looking for involvement and involvement of nerves and vessels. And I think MRI has a role in differentiating chordomas and chondrosarcomas, which I'll talk about. And it has a big role in post-treatment imaging. So my bugbear is that a lot of our radiology practices do whole brain imaging with a few thoughts to skull base imaging at the end, whereas the whole thing should be focused on the skull base. So you have a minimal number of useful sequences and the patient's not moving. Whereas if you do the whole brain first, then you concentrate on the skull base, the important money sequences are at the end when the patient starts moving about. So these are the sequences that are money sequences, are coronal and axial T1. We do the T2 FATSAT in 3 dimensions, and we do a post-gadolinium 3D T1 FATSAT and 1 2D FATSAT, which is usually slightly later. And before gadolinium, we do a DWI scan. So these are our basic 7 to 8 sequences which we do. This is a typical chondrosarcoma. It's lateral, it's iso-intense to brain and skeletal muscle on T1. It's very T2 hyperintense because of the cartilage matrix. And on the 3D postgad sequence, which is an early postgadolinium sequence, you don't see much enhancement. This is a chordoma on T1. This lesion is hypointense, but this one is more typical iso-intense to skeletal muscle, but it's got hyperintense elements, which are uncommon, but this is intralesional hemorrhage, which you can see on the SWI sequence. So again, on T2 weighted sequences, chondrosarcomas are bright because of the cartilage matrix. And chordomas are bright because of the mucin content of the phyzoliferous cells that form the chordoma. This is a slightly atypical chordoma because of the low signal, which is predominantly hemorrhage, but a lot of it is T2 markedly hyperintense. Another chordoma, T2 hyperintense. This is a lesion at the lower end of the clivus, again, T2 hyperintense. And this was a slightly atypical chondroid chordoma, but this was very T2 hyperintense. What happens after gadolinium? So, as I said, we do an early 3D T1 post-gadolinium, which a lot of our chondrosarcomas might not enhance on, or we see this stippled chondroid type enhancement, which we see in enchondromas or chondrosarcomas elsewhere. But if we wait a bit, the lesion usually enhances. And this is the same patient. This is the early scan where we don't see any enhancement following gadolinium, but a bit later on the 2D sequence, 2D post-gad T1, it's filled in with contrast. Another lesion which is filled in with contrast on the delayed imaging. And chordomas tend to enhance variably. So the lesion at the lower end of the clivus doesn't enhance much, but the mass at the top arising from the dorsum celli, there's quite a bit of enhancement. So how do we differentiate chordomas from chondrosarcomas using MRI and CT? So one of the things is sight, but theoretically chondrosarcomas can also occur in the midline. But probably an important thing is the ADC. So this paper came out in AJNR in 2013. And this was the first paper that looked at chordomas and chondrosarcomas with their DWI numbers, so the ADC value, which we can get by putting a cursor on our PACS on the lesion. The basic idea is that chondrosarcomas have a lot of mobile water molecules and proton molecules, so they show facilitated diffusion and they have relatively high ADC values. There's the chondrosarcoma forward there around the carotid. Whereas chordomas tend to show restricted diffusion, being hypercellular and large mucin content, so the water can't move about. So they tend to show diffusion restriction and have lower ADC values. So this is said to be a very good way of differentiating between the two in the literature. We haven't used it as much, probably because most of these patients end up having biopsy, but we should be using it. And eventually, I don't know whether it'll ever stop them needing a biopsy, but that would be the logic behind this. So there are some additional sequences we sometimes use. So we'll use a cysternographic sequence, which you might know as the SPACE or Fiesta or CIS, depending upon the type of magnet you're using. And these are sequences which look at the basal cisterns. They don't have the CSF motion artifact we see on T2 weighted sequences. So we can pick out small structures like nerves and veins and arteries and work out if there's involvement. We can also go to angiography with time of flight sequences, and post-gadolinium venography is sometimes useful. So this is an example of a cysternographic sequence with chondrosarcoma laterally in the petroclival fissure with the trigeminal nerve coming into Meckel's cave. This is a large midline chordoma covering the internal auditory canal and effacing the 7th and 8th nerve complexes. This is a chondrosarcoma going forwards and encasing the internal carotid artery. You can make that out on the time of flight sequence with flattening of part of the margin of the ICA. This is a more typical lesion, chondrosarcoma, right up against the horizontal intratemporal carotid artery, but not really affecting flow. This is the 3D reformat of that raw time of flight sequence, the source image. When do we use MR venography? Most often we're using it to look at the contralateral side to see if there's adequate venous drainage. There's a chondrosarcoma indenting the transverse sinus there, the sigmoid sinus, and you can see there's flow on both sides, slightly reduced flow on the right side, but there's dominant venous drainage on the left side, which is of use. Now, this is a lesion that's completely occluded the sigmoid sinus, and you can see the abrupt truncation there, and you're relying on adequate venous drainage on the contralateral side. So that's where venography comes in helpful. MR is also helpful for looking at growth patterns, but as you know, chordomas can grow laterally, superiorly, inferiorly. They can go anteriorly through the cavernous sinus to the orbital apex, as this one did. The chondrosarcomas can grow into the jugular fossa. So you've got your eagle's head with the jugular foramen on this side, and this is infiltrated by the chondrosarcoma, which gets into the base of the clivus there. And there's the hypoglossal canal underneath. This is the one that indents the jugular vein. And this is the lesion that goes forwards into Meckel's cave. And you can pick up transdural growth into the cerebellopontine angle cistern. So post-op MRI, this is my second bugbear. So you've got to do them using the same sequences that you did before. You've got to have the same measurement reference points to get the adequate dimensions, accurate dimensions, and you've got to use the same sequences that you're using your measurement on. This means that you must provide key images for the next radiologist to look at and work out how you measured this. So this gives you an idea of how a tumor changes after surgery. This is a chondrosarcoma in the petrous apex. You can see this is before surgery. This is the endoscopic footprint there where it's been debulked anteriorly. And then later on, the patient had a suboccipital craniotomy to debulk the cisternal portion of the tumor. So this was what it started with, and this is what it ended up with. Now, Jeremy is going to take over now and talk quickly about potential problems.
Thanks. So there are several sites from which potential mimics of clival chordomas where they can arise from. Of course, you can have other bone-centered processes within the clivus, both malignant and non-malignant. You can have pathology that's arising anterior to the clivus, for example, within the sphenoid sinuses and invading posteriorly. And you can have pathology that's centered posterior to the clivus, for example, with durally based lesions. This is an example of fibrous dysplasia of the clivus. The image on the left is a sagittal post-contrast T1 weighted slice, and this shows that the clivus is expanded and heterogeneously enhancing. Fibrous dysplasia does occasionally get misinterpreted for neoplasia, but in this case, on the right-hand image on CT, you can see that the bone has a granular, sometimes described as ground glass appearance, and that's characteristic of fibrous dysplasia. You can have tumors arising from the paranasal sinuses, for example, sinonasal carcinoma. This is an example of an aspergilloma from within the sphenoid sinuses that has invaded posteriorly into the clivus. On the image on the right, which is T2 weighted, you can see the low signal within this lesion, which is often seen with fungal infections in the paranasal sinuses. Here are some examples of lesions that can occur anywhere in the skull base, including the clivus. The appearance of metastases will depend on the site of the primary. Metastases from prostate cancer, for example, are usually sclerotic. This is an example of a clival metastasis from a colorectal primary. On the left-hand image, you can see a T1 weighted slice, and this shows that the normal bright signal within the clivus that's caused by fat within the bone marrow has been replaced. And on CT, this lesion has a mixed lytic sclerotic appearance. This is an example of lymphoma that's primarily involving the clivus. Again, on the pre-contrast T1 weighted sequence on the left, the normal fatty marrow signal has been replaced, and this region is heterogeneously enhancing. This turned out to be histologically diffuse large B-cell lymphoma. This patient presented with diplopia, and you can see a plasmacytoma that's centered on the clivus and has invaded into the cavernous sinuses bilaterally. And this is a meningioma within the prepontine cistern. This lesion is homogeneously and avidly enhancing, and you can see both superior and inferior to the lesion is the dural thickening that you'll usually see with meningiomas, irrespective of the site. Here are some notochordal variants that I'll be talking about next, so namely equidosis physolifera and benign notochordal cell tumors. EPs like chordomas arise from notochord remnants, but unlike chordomas, EPs are benign lesions and usually asymptomatic. Their appearance, both radiologically and histologically, can be similar to chordomas. They have a similar distribution, and EPs are also usually T2 hyperintense, but EPs will often have a pedunculated appearance with a bony stalk and will lack the aggressive features of particularly larger chordomas. Here are two separate examples of EPs within the prepontine cistern. both showing the pedunculated appearance on the bottom right image. On CT, you can also see the bony stalk. Benign notochordal cell tumours are histologically distinct from chordomas and EPs. They have a similar distribution and are also usually T2 hyperintense, but BNCTs tend to be bone-centered and are usually mildly sclerotic, and will also lack the more aggressive features of chordomas. And here's an example showing the mild sclerosis on CT and T2 hyperintensity on MRI.
Thank you for your attention. Thanks.
That's great. That's a fantastic introduction. We might move straight on to you, Shaan, if you just want to share your screen with everyone and share your experience with us.
Well, thank you very much for having me. I'm just going to share some lessons I've learned in terms of the management of skull-based chordomas and chondrosarcomas from the multimodal and surgical standpoint. You certainly heard a great radiologic overview of these lesions. You know, to provide some bigger perspective here, you know, chordomas and chondrosarcomas really fall under the umbrella category of primary bone sarcomas. And looking at our own practice, chordomas, chondrosarcs, and osteosarcs account for about 90% of the bony sarcomas we see in the skull base in our own surgical practice. And, you know, for quite some time, there was some historical pessimism regarding the long-term outcomes of the management of these lesions when there was skull base involvement. And over time, looking at our own practice, you know, we are seeing improvements in 5 and 10-year disease-specific survival because of a lot of advancements listed on the right here. And I'll sort of cover those key advancements really from the practical standpoint in terms of how they factor into overall management. You know, the first important advancement that occurred was really the enhanced histologic diagnosis. You know, historically, the reason why the results for chordomas and chondrosarcomas were reported together is that the sarcoma pathologist historically had a hard time differentiating these tumors from each other. But with the identification, for example, of brachyury and other sort of histologic features, it has become much easier to diagnose these tumors. And as a result, we've been able to better track their natural history. And you can see the diagnosis is important is because these bony sarcomas behave across a spectrum, where on one hand you have giant cell tumor, and on the other hand have osteosarcomas. And chordomas and chondrosarcomas certainly have divergent behavior. And as I'll show you within the chordoma and chondrosarcoma categories, there are either histologic or molecular subtypes that correlate with differential long-term behavior that needs to be factored in terms of treatment decision-making. But I'll focus first on chondrosarcomas. And histologically, we break these chondrosarcomas down into 3 different subtypes: the conventional subtype, the mesenchymal subtype, and the dedifferentiated subtype are the 3 subtypes that we see in our own skull-based practice. The conventional subtype chondrosarcomas are also histologically broken down into 3 different grades, grades 1, 2, and 3. And the reason why these histologic subtypes and grades matter is that they ultimately correlate with long-term outcomes, overall survival, risk of local recurrence, and risk of metastatic spread. So looking at, for example, the conventional subtype tumors, these fare much better than the mesenchymal and dedifferentiated chondrosarcomas. But when you look at the conventional subtype tumors separately by histologic grade, they behave across a spectrum where on one hand you have the conventional grade 1 chondrosarcomas, where with just surgery alone overall have an extremely favorable outcome. And on the other hand, the conventional grade 3 chondrosarcomas, even with surgery and radiation therapy, as I'll show you, have a median PFS of 34 months, which is barely better than the mesenchymal and dedifferentiated chondrosarcomas. Now, histology not only correlates with long-term survival and risk of recurrence, but also guides the goals of therapy. So, for example, when we look at the conventional subtype tumors, the chondrosarcomas, when they occur in the skull base, when these patients recur, 100% of the recurrences are all local. These patients do not go on to develop metastatic spread. And as a result, with the conventional chondrosarcomas, we know that the goal of therapy primarily is local control. And that's why the treatment decisions really revolve around the use of local therapies such as surgery and radiation therapy. On the other hand, when we look at our mesenchymal and dedifferentiated chondrosarcoma population, when those patients develop disease progression, not only do they develop local recurrence, but 65% of those patients will go on to develop metastatic spread, such as pulmonary metastases. And so as a result, with these mesenchymal and dedifferentiated chondrosarcoma, the treatment decision-making not only incorporates surgery and radiation therapy for local control, but also the incorporation of systemic therapy to downgrade the risk of metastatic spread, as I'll cover in a little bit. Now, sort of focusing first on the role of radiation therapy for conventional subtype chondrosarcomas, where really the goal of therapy is local therapy. When you look in the literature, the challenge that we have in terms of figuring out when to use radiation therapy is really the combined reporting of chordoma and chondrosarcoma outcomes in the literature. And then when you look at those series in the radiation oncology literature that report outcomes for chondrosarcomas, very rarely do they report histologic subtype and grade. And when they do report histology, they tend to include a higher percentage of grade 1 chondrosarcomas. And as I showed you 2 slides ago, really with the conventional subtype chondrosarcomas, they behave across a spectrum, where really with the grade 1 chondrosarcomas, even without radiation therapy, they have overall a very favorable prognosis. And so this, I think, drives a lot of the confusion in terms of when to use radiation therapy in the postoperative setting. And so several years ago, we looked at our own experience institutionally, and what we demonstrated certainly is with the conventional grade 2 and grade 3 chondrosarcomas, adding on postoperative radiation therapy had a significant impact on local control rates. With the grade 1 chondrosarcomas, we tend to observe them and haven't noticed any issues. As we try to delve further into this, really the question that has come up, I think, in our own practice and in the literature is with the conventional grade 2 chondrosarcomas, do we still have to add on radiation therapy as surgery has gotten better? And to help answer this question, we recently led a multi-institutional registry combining conventional grade 2 chondrosarcomas from our own practice, UPMC, and Stanford. And the study objectives, one, were really to look at the impact of a radical resection on long-term outcomes, but more importantly, really what was the impact of postoperative radiation therapy with the conventional grade 2 chondrosarcomas, and was there a difference with regards to which radiation modality was used? And really the take-home points from that study that with the manuscript currently being currently under review is that when we look at the conventional grade 2 chondrosarcomas where a subtotal resection has been achieved, adding on postoperative radiation therapy has a significant impact on tumor control rates and really significantly decreases the risk of recurrence. And interestingly enough, with the gross totally resected chondrosarcomas, where I think a lot of centers will actually just observe those patients, adding on early postoperative radiation therapy still has a significant impact on long-term outcomes. Now, as I mentioned with the mesenchymal and dedifferentiated chondrosarcomas, because of the risk of metastatic spread, really chemotherapy is part of the treatment protocol. And for us, we tend to use this in the neoadjuvant setting. And this is based on data that was published several years ago, looking at chondrosarcomas at all sites, including the spinal column and long bone sites. And what this group demonstrated in a cohort of 180 patients is that with multimodal systemic therapy, that there's a significant decrease in recurrence rates with the mesenchymal and dedifferentiated chondrosarcomas. And when our own practice, what we tend to use this then is in the preoperative setting. So this is an example of a dedifferentiated chondrosarcoma I treated several years ago, and we administered neoadjuvant chemotherapy, and you can see a significant decrease in the radiologic extent of disease. And what we find is that the use of neoadjuvant therapy not only decreases the risk of metastatic spread, improves local control, but similar to, for example, SNUCs in terms of sinonasal cancers, also really can be used as an organ-sparing strategy and help us tailor our surgical strategy too. And so with the mesenchymal and dedifferentiated chondrosarcomas, really neoadjuvant chemotherapy along with surgery and radiation therapy is our treatment paradigm. So sort of summarizing how we view the skull-based chondrosarcoma management strategy, with the conventional histologic subtype tumors, surgery is really the foundation of the treatment, but then in the postoperative setting, with the grade 1 chondrosarcomas, we tend to observe them. With the grade 2 chondrosarcomas, we get a gross total resection Historically, we used to observe them, but I think based on that data now, we might lean towards early postoperative radiation therapy. With the grade 2 subtotally resected chondrosarcomas, definitely those patients get postoperative radiation therapy. And then with the grade 3 chondrosarcomas, regardless of extent of resection, the data shows that adding on postoperative radiation therapy is key. And then with the mesenchymal and dedifferentiated chondrosarcomas, these tend to be much more extensive multi-compartmental tumors. So they end up getting a biopsy anyways. And with the biopsy demonstrating mesenchymal and dedifferentiated subtype, we start out with neoadjuvant therapy. And then based on the extent of necrosis as a result of that neoadjuvant chemotherapy, that helps tailor the postoperative chemoradiation therapy strategy. Now, sort of moving on to chordomas, traditionally we used to view this as a single histologic entity, but the reality is that it behaves across the spectrum also. And for example, the UPMC group has demonstrated that with FISH analyses and looking at 1p36, 9p21 status, that correlates with long-term recurrence risks. There are also clinically applicable biomarkers that can also help predict the risk of recurrence after surgery. In our own practice, we tend to use Ki-67 because it's a relatively cheap marker that also is a good way to predict the risk of recurrence. And ultimately, as I'll show you, we factor that in terms of tailoring treatment strategies after maximal surgery. Now, for quite some time, there was a lot of controversy regarding the role of postoperative radiation therapy for skull-based chordomas after surgery. And I think, the pendulum has swung from not using radiation therapy at all after maximal resection to using radiation therapy in every single patient. And in this SEER study, this nationwide study that was done several years ago, what this group demonstrated is across all skull-based chordomas that the incorporation of postoperative radiation therapy certainly has made an impact in local control rates. And I think the reality is that as we work to better develop histology-specific treatment strategies, that there are probably a subset of patients where we definitely need to use radiation therapy postoperatively, but ultimately a subset where we can just get away with surgical resection alone. Certainly, I'm not going to delve too much into the radiation oncology aspect of treating skull-based chordomas, since the next speaker is going to likely cover this. But from the surgical standpoint, it's important to understand that really good radiation therapy is not a substitute for a subtotal resection with regards to surgery. When we look at the factors that correlate with long-term outcomes after patients undergoing proton therapy, we know that dose matters. The ability of the radiation oncologist to deliver those high doses to 95% of the gross tumor volume matters. The presence of the volume of radiographic disease present and the location of that disease against radiation-sensitive structures also impacts local control rates and the risk of radiation toxicity. And so the point is that achieving a radical resection with surgery certainly improves the chances of success with radiation therapy. And in situations where a radical resection may not be feasible, at the very least, resecting as much disease as possible away from radiation-sensitive structures so there is as little radiographic disease as possible, ideally less than 15 to 20 cubic centimeters, is the next best thing that we can do in terms of optimizing radiation oncology outcomes. Now, in terms of systemic therapy for skull-based chordomas, this traditionally was not part of the treatment paradigm. But as we look at our own experience, we have recognized that there are two sort of cohorts of patients that really benefit from at least considering systemic therapy options early in the treatment paradigm. One category really are those patients with biologically aggressive disease, patients with high Ki-67. And this is an example of a patient that I treated, multiple previous surgeries, multiple rounds of radiation therapy done elsewhere, and this patient presented to me with recurrence. And certainly with surgery, I can get a radical resection, a clean-looking MRI scan, but with the high Ki-67 and no re-irradiation possibility, this is an example of a patient that would benefit from systemic therapy. And then the other cohort of patients are really those patients that go on to develop metastatic spread. Several years ago, we demonstrated, looking at our own institutional experiences, that ultimately about 8 to 9% of skull-based chordoma patients will go on to develop metastatic disease, such as systemic metastases or leptomeningeal disease. And this was also demonstrated by the group in Paris. And so it's this group of patients also that we certainly consider systemic therapy as part of the treatment paradigm. And as a result of those sort of cohorts of patients, this is what drove us to look for systemic therapy options in our own patient population. And several years ago, our group reported the largest reported experience with the use of immune checkpoint therapy for advanced chordomas. And what we demonstrated with, for example, the use of anti-PD-L1 therapy, that we achieved a radiographic response rate in nearly about 24% of patients, which was much better than previously reported with other systemic therapy options. And on the right is an example of a patient of mine that we put on systemic therapy. So this is a lady who presented with a low clival craniocervical junction chordoma, and ultimately I achieved a gross total resection using a two-stage approach. But you could tell intraoperatively that this was an invasive tumor as it invaded into the parapharyngeal space and all the craniocervical junction ligaments. And so while I got a clean-looking MRI scan with such a high Ki-67, my feeling was that just doing radiation therapy alone postoperatively would not be adequate for this patient. So in addition to radiation therapy, we put the patient on Pembro. Ultimately, for insurance reasons, the patient had to come off of Pembro. And about 6 months coming off of Pembro, she developed a metastatic site lower down in the cervical spine. And so we ultimately just put the patient back on Pembro and then treated with radiation therapy later on. But just simply putting the patient back on Pembro, that site melted away. So in terms of how we tailor our treatment strategies for skull-based chordomas, certainly the goal of surgery is a radical resection, but based on Ki-67, if it's a low Ki-67, ultimately we observe, and these patients tend to be amenable to a gross total resection, so it's rare to get a subtotal resection with this group. With the intermediate type chordomas, we tend to offer postoperative radiation therapy after maximizing surgery. And then with the really bad actors, certainly we consider systemic therapy, and we try to be rational in terms of whether we use immune checkpoint therapy or targeted therapy options. Now, sort of quickly breeze through the surgery aspect of this in the interest of time. Well, we know that the goal of surgery is ultimately achieving a radical resection. And we've learned this from the spinal oncology, musculoskeletal oncology literature. Now, while the goal in with spinal column chordomas and chondrosarcomas is an en-bloc resection, ultimately in the skull base, while we can't achieve an en-bloc resection, we can do at least an anatomic resection of each compartment of the tumor. And what that means is for a petroclival chondrosarc like this, is to drill out the midclavus, the petrous apex back to anatomic margins, such that the carotid artery is skeletonized, and then resecting the dura widely, and then resecting the subarachnoid portion of the tumor. And what we and several other groups have demonstrated is that when surgery is performed in that anatomic fashion, so doing much more than simply an intralesional curettage, that maximal surgery does have a significant impact on long-term outcomes for chondrosarcs, chordomas, and then osteosarcs for completeness sake. Now, I think what's common to both the clival chordoma and the chondrosarcoma patient population are really the surgical challenges in terms of dealing with midclival chordomas and petroclival chondrosarcomas. When we look at the petroclival synchondrosis, that extends from the inferior aspect of foramen lacerum down to the medial aspect of the jugular foramen. And as you heard earlier, a good number of chondrosarcomas that we see, about half of our patient population, those chondrosarcomas tend to be centered around the petroclival junction. And then when you look at the midclival chordomas, the anatomic boundary of the midclavus is that synchondrosis. And historically, whether with straightforward endoscopic or lateral open approaches, there have been challenges with achieving those radical resections that I talked about. When you look at the open transpetrosal approaches, they certainly provided great access to the petrous portion of the temporal bone and the mastoid portion of the temporal bone, but both were limited with regards to their access to the synchondrosis. And ultimately, when we looked at our own historical experience, there was a lot of residual disease medial to the jugular foramen. And then when the endoscopic approaches came along, certainly with angled endoscopes and angled instruments, you can get out to the synchondrosis. But ultimately, the carotid artery and the pterygoid plates limited our ability to really drill out this area widely and really access disease extending into the jugular foramen. And this is really where the transpterygoid approaches came into play to really improve resection outcomes, and then adding on the CTM approach. And sort of quickly taking you through sort of systematically how we use those approaches. This is an example of a previously treated grade 2 chondrosarcoma that I took care of ultimately when they had residual disease, and they came to us, and you can see involvement of the cavernous sinus, involvement of the clivus, and going all the way out to the junction of the vertical petrous, horizontal petrous carotid artery. And so here, I ended up treating this patient the transpterygoid approach. Very simply, what that consists of with regards to the medial maxillectomy here, what we tend to do in our own practice is taking down the middle turb on that inferior ipsilateral side, and then trimming the back 2/3 of the inferior turb, so that provides a sufficient lateral access to get out to the jugular foramen. The next step is really the PPF dissection, and really getting vascular control of the distal branches of the IMAX, and really clipping the sphenopalatine artery, so that really allows you to laterally mobilize the pterygopalatine fossa, and then gain access to the infratemporal fossa there. The next step really is this dissecting the inferior head of the lateral pterygoid muscle in a subperiosteal fashion off the lateral pterygoid plate. And what this really allows you to do is lateralize those contents of the infratemporal fossa, such that once you're done drilling the pterygoid plates, you have sufficient access to get out to the jugular foramen. And then the next step after doing that medial infratemporal fossa dissection, of course, is just drilling out the pterygoid plates. And really, in order to get access out to the jugular foramen of these petroclival tumors, that means really drilling out at least the medial pterygoid plate, and typically drilling out the lateral pterygoid plate. And simply what I do is, identify the inferior head of lateral pterygoid muscle, V2, the Vidian canal. And at that point, you have all your anatomic boundaries of the pterygoid wedge identified. And then very efficiently, you can resect the pterygoid plates back. And you're done once you have this view here at the end, where you have V2 skeletonized back to Meckel's cave, V3 going down to the infratemporal fossa, and the Vidian taking you back towards the junction of the periclival and lateral segment of the carotid artery. The next step is really mobilizing and skeletonizing and mobilizing the carotid artery. And for these petroclival tumors, the segments I tend to mobilize are at least the periclival and the lateral segments. And then, of course, thinking about proximal and distal control for more complex tumors, having access to the vertical petrous ICA and the cavernous ICA, so that you have circumferential and proximal and distal access to the carotid artery. And then the carotid artery ultimately needs to be mobilized out. And the next step in terms of gaining access to the petroclival synchondrosis is dealing with the eustachian tube. And oftentimes with more aggressive chondrosarcomas and chordomas, where I know we're going to do radiation therapy, I tend to just resect the medial aspect of the eustachian tube to enhance that access. And here's my sucker tip on the right petroclival synchondrosis. Here's the lateral carotid artery. Here's the hypoglossal canal skeletonized for view there. With the more indolent chondrosarcomas, instead of resecting the eustachian tube, what I tend to do is just detach it from the skull base and mobilize it anterolaterally, so that you have that access, but you don't incur that risk of conductive hearing loss. And so here's a preoperative scan here on the left and the postoperative scan on the right, showing complete resection. And you can see that we got out to the vertical petrous ICA. And sort of just wrapping up here, show an example of where we still use open transpetrosal approaches. So this is an example of a patient with midclival chordoma. You can see some calcification within the tumor and along the brainstem here, and going up right against the vertebrobasilar system. And so here there was disease extending lateral to 6th and lateral to the 3rd nerve. So I started out endoscopically doing a transclival approach, and cleared all the calcified disease off the vertebrobasilar system. Here I'm using the ultrasonic aspirator along this calcified portion of the tumor up against the brainstem. But because of how calcified the tumor was up against the arachnoid of the brainstem, no matter how much I tried to do sharp dissection, I could not clear that portion of the tumor away from the brainstem. And so what I felt during the endoscopic approach is that I ultimately reached a point where I had maximized what I could remove safely. And then I backed this patient up with the transpetrosal approach. So I did a combined controsal from the left side. Here you can see the pras probe on the vestibulofacial complex, the retractor on the petrosal surface of the cerebellum, and here are the lower cranial nerves. And then working above the trigeminal nerve against the basilar apex, clearing tumor off the basilar apex. And here's a view at the end, showing basically a complete resection, and the preoperative scans on the left and postoperative scans on the right. And so this is an example of a patient where we still need to use transpetrosal approaches, either based on the lateral extent of disease within the bony skull base or in the subarachnoid space. And so endoscopy certainly has made an impact, but it's important to have that comprehensive surgical toolbox. And my last slide here, really the points that I want to make with this short overview on chordomas and chondrosarcomas is really the overall treatment strategy needs to be tailored to histologic subtype and grade. And I think this is the same for both chordomas and chondrosarcomas. Ultimately, from the surgical standpoint, the goal is an anatomic resection of each compartment of the tumor. So I always look at the bony skull base, and then the extra compartmental soft tissue compartments, and systematically you want to achieve a gross total resection in each one of those compartments. And then hopefully, as I showed you in the last few slides, is that while the expanded transpterygoid approaches have really made an impact specifically for midclival, petroclival pathology, there's still a need for the open approaches in terms of achieving a radical resection. And then this is our group here at Anderson. Thank you very much again for allowing me to sort of share some of our experience.
That's great. Thanks so much, Shaan. I really appreciate that. That was a fantastic talk. I've just got two questions. One is, does the age of the patient play a role? So if a patient presents who's 76, who's got a chondroid lesion of the skull base versus a 26-year-old. And the second thing, is there a role for observation of some of these lesions which can grow very slowly, particularly your lower grade chondrosarcs? Not so much chordoma potentially, but those lesions. Do you argue back and forth in your MDT sometimes about those decisions?
Yeah, great question. So about the chondrosarcomas, it definitely comes up. I think that a subset of the chondrosarcomas, just grade 1 chondrosarcomas, are often can be confused for enchondromas, right? Which is the benign sort of precursor to the grade 1 chondrosarcomas. And so, the way I tend to tease those out on imaging is, if it's a T2 hyperintense lesion, not enhancing even on delayed MR scans, and on the CTA, not extremely lytic, that might argue a little bit more in favor of an enchondroma. And if there's doubt, you can always get a PET, and they never light up on a PET scan. So for really indolent, benign appearing petroclival lesions that really look like an enchondroma and they're asymptomatic, I tend to observe them and make them prove to me that they need surgery. The conventional grade 2 and grade 3 chondrosarcomas tend to be obvious. They tend to be symptomatic and or they tend to be enhancing and much more extensive. And so there's less of an argument to observe them and more of an argument to treat them. With chordomas, what I would say is that, recognizing when you're dealing with EP versus a benign notochordal tumor, and then age definitely factors into that. So that category of patients of clival lesions, I tend to observe. Otherwise, an extensive chordoma in an older patient, I think that tends to be a tougher conversation. If they're able to tolerate surgery, oftentimes those patients at least want to have surgery done. And then the question about radiation therapy and those risks, definitely a part of the decision-making afterwards with them.
Right, thanks so much.
Can I just ask, James, do you think, Shaan, like when I see echondrosis falciparum, it's often like multiple little T2 enhancing nodules, not just one simple one. It's often like a little collection of them. That's just my mojo of it. Do you think that's borne out in your experience?
I tend to have the same experience also, is that they'll have like multiple nodules on it. But then what's really reassuring too is, again, when you look at the CT findings, often sclerotic or very well-defined edges, but it's not just like a single nodule, but maybe like a collection of berries, for example. That might be the best analogy.
Yeah.
Great. Well, we might let Matt talk now. Matt, I think Shaan's covered some of his thoughts on radiation, but I'm interested to hear your experience, particularly potentially some patients who've almost had upfront radiation for treatment of their lesions. So thanks so much for contributing.
Thanks, James. You can hear me okay?
Yep.
Great. So yeah, thanks for the opportunity, James. Shaan, awesome talk, and thanks for covering a fair bit of what I need to. Look, I thought for something for this audience and maybe a little bit different, what I thought I'd do is, I appreciate it's late in the night, but I'll do some basics of the physics of protons and photons, because if you're treating skull-based tumours, you need to have a working understanding of the pros and cons of protons and photons. Shaan has covered some of the data, and I'll just cover a little bit of that as well, and then I guess show some of the approaches for different cases that we've seen. So look, I guess what I want to do is just highlight this graph down the bottom. The difference between photons is you deposit the energy at a depth, and then there's this tail, which means exit dose or low dose treatment. Protons, which is the blue, you do get some entry dose, but you do get this dose dumping at what's called the Bragg peak. So I guess in theory, and that may not necessarily mean in practice, but in theory, you can get dose with less dose outside of your target. And I guess I say in theory because there's a number of considerations, and part of this is the shaping of the beam or collimation, targeting, which comes down to how well you can target through your image guidance, and the degree of stereotactic precision that various machines can have, and whether or not you can deliver that with sub-millimeter precision. A quick segue, it's interesting, there's a rich Australian history, and this slide's from a colleague of mine in South Australia, Peter Garaski, which, so Australia and so William Bragg and his son Lawrence were actually awarded the Nobel Prize for their work into, I guess, radiation physics and discovery of the Bragg peak. So it's not surprising that, you know, the centre down in Adelaide, which I'll talk about in a second, is going to be called the Bragg Centre. In terms of the main photon machines that I guess you need to have a working understanding of, you've got your stereotactic adapted linear accelerator on the top left, obviously the gamma knife centre, and lower left, the cyber knife. So all of these are used in the management of skull-based tumours. In terms of your stereotactic adapted linear accelerator, it really does have a few extra bells and whistles on it to enable that sub-millimeter precision. And I guess I wanted to highlight that nowadays with modern photon stereotactic delivery, you can use a 0 to 1 millimeter margin on your target. So very accurate in terms of delivery of photon treatment. Gamma knife is a dedicated brain and skull-based machine delivering, you know, usually dose treatments in 1 to 5 fractions. You can see there, if you're using one treatment, it's usually with a frame. If you're using multiple fractions, it's with a mask. Great body of evidence and evidence also, which I'll touch on in this presentation in chordoma and chondrosarcoma. CyberKnife is also available in Australia. It's another radiosurgery system. Most of the work it does is outside of the skull base and brain, but certainly can be used and is very effective, similar to other photon machines in the treatment of skull-based tumours. This is a proton machine. As you're probably aware, we don't have protons available locally in Australia. There is a centre that is being built in Adelaide, that being the Australian Bragg Centre. And once again, just acknowledging Peter Garaski for these pictures. This is how it looks currently. In terms of timeline for functionality, I still think we're probably at least a year or two away. And unfortunately, those timelines keep shifting. I guess for those of you that were present at NSA, I don't know if many of you were there a few weeks ago. I presented this, so I apologise if you were there. But it's worthwhile for those of you not in the game of radiation to have a working understanding of what's out there and what's said and what's actually real. So I had this game called Protons, Photons, Fact or Fiction. So there's this conception out there that protons are more effective in killing tumours. Now, firstly, what I'd say is biologically, they work very similarly. And dose is dose. It's just how you get it in. So if you can get the same dose in with protons, it's going to be the same with photons. In terms of protons cause less tissue damage. Now, this one is a little bit more complicated. And it comes down to theory in terms of whether you consider the volume receiving high dose more important or the region getting low dose. Now, there's no doubt with protons that you get less low dose, but you may actually get a higher volume of high dose, and I'll touch on that in just a second. Part of this comes down to the accuracy. So it's, I guess I say fiction there, that protons are more accurate. In fact, they're not. When you look at the modern day Linacs, gamma knives and cyber knives, you can use a 0 to 1 millimeter margin in terms of the accuracy of delivery. Now, with protons, they use what's called robust optimization, which means they have an error margin, and that's usually around 3% and 3 mils. So if you look at that, the modern day photon delivery in terms of delivery of treatment and knowing where that dose is going is actually more accurate than protons. I'm not going to go into the cost, but it's suffice to say that protons are more expensive. Look, I think the treatment paradigm for management of chordoma and chondrosarcoma, as Shaan indicated, is certainly more nuanced now. But in general principles, it's maximum safe tumour resection, and in most cases, adjuvant high-dose radiotherapy. And in those that cannot have surgery, then there is a role for definitive treatment. Shaan touched on this, and I'm certainly on board. And this is the data from chondrosarcoma, which shows that obviously the mortality rate increases with increasing grade. And if you take all comers, there is certainly an advantage, a survival advantage in the addition of radiotherapy. But when you look at those conventional grade 1 chondrosarcomas, they actually do very well. So I do think that there is a strong case to observe those patients and omit radiotherapy. In chordoma, I think the rationale for omitting radiotherapy is less robust. As you know, these tend to behave in a slightly more aggressive fashion. In terms of radiation dose, look, to be honest, I hate these dose curves, but this one tells a story. When we're talking chordoma and chondrosarcoma, dose is key. And basically what this shows is as you get more dose in, your chance of tumour control goes up. But obviously that needs to be balanced with the risk of causing permanent side effects because of your radiation treatment. Now, so if we just do some basic maths here, if you want to get above 80 to 90% control, you need to get, depending on histology, and I'll talk about that in a sec, somewhere in the mid 70 gray. Now, if you're doing that as fully fractionated treatment, that's daily treatment over 7 to 8 weeks. I guess the significance of that now with modern deliveries, you can punch it in a smaller number of treatments. Now, that's not applicable in all cases, but just to give you a guide, to get up around 90 grays, 90 gray as a fully fractionated treatment, so 2 gray per day, that's equivalent to somewhere in that 80 to 20 gray range as a single dose. In terms of dosing, look, I think most conventional people are looking at using for chondrosarcs somewhere in that 70 to 74 gray. And I say dose equivalent because there's different ways to get that dose in. And chordoma is slightly higher. Now, I guess this picture gives you a schematic of potential differences between protons and photons. Now, as I say in meetings, the best way to make a proton plan look good is to compare it to a really crap photon plan. And I can assure you that that photon plan there looks nothing like anything I would accept as a reasonable treatment. But it is fair to say that target coverage is comparable between protons and photon treatment. There may be some reduced low dose wash with protons, but that is largely dependent upon the geometry. Just in terms of some of the data, this is proton data. Once again, one of the issues here, combined data sets of chondrosarcomas and chordomas. I think Shaan has indicated, obviously, the chondrosarcomas do better in terms of local control. And in this series, your chordoma, I think it's a 7-year local control, above 70%, but much higher for chondrosarcomas. I think the most interesting part of this, and once again has been touched on previously, is factors that predict for local control. And we know that factors that predict for local control typically also correspond to survival, and that's compression of structures, and I'll talk about that a little bit. And these are what I call dose-limiting structures, so structures where it stops you getting in enough dose to control the tumour, particularly brainstem optic apparatus. Also, volume of GTV here, the cutoff was 25 cc's, but I think on principle, the less residual volume in the adjuvant setting, the better patients will do. And not surprisingly, chordomas don't do as well as chondrosarcomas. If you look at the photon data, there's actually a lot of data out there, and the early data actually shows pretty poor local controls. But it's, once again, mixed series. But when you look at the modern series, where you're getting equivalent doses above 70 gray, you'll actually find local control rates very similar to that of the proton literature. Once again, similar results that local control is associated with overall survival and local control is linked to volume of residual disease. Grade 3 and above toxicity, very similar to the proton data at less than 10%. So look, I think this has been mentioned, and this is obviously a grade 2 chondrosarc. When these are presented in meetings, the things that I'm always looking at, well, how close have we got disease to the brainstem, because that's dose limiting for me, and also to the optic apparatus. In terms of what's treated, if you look at the guidelines, and guidelines are guidelines, they're not always evidence-based. We do treat both chordoma and chondrosarcs in a very similar way. I have to say the margins that I use are probably a little bit less than some of the guidelines. you are obliged to treat the whole preoperative tumour volume. Here they would say 10 to 20 mil margin on that. I would rarely use above 10 millimetre margin, and you're always trimming it based on anatomical boundaries. And then there is a boost volume to any site of either definite residual or high-risk microscopic disease. To be honest, I rarely use more than 5 mils, and often when I'm using gamma knife, which I'll show you in a minute, I don't use any margin on that. James did mention the role of upfront treatment. Look, there is data on upfront treatment, and this is the gamma knife data, 71 patients. And not surprisingly, those patients treated for salvage did worse. Those patients with higher volume did worse. There is a significant impact on dose, and you do need to get above 18 gray. I have to say, I don't tend to treat chordoma rather with gamma knife, and you'll see this picture here is obviously a chondrosarc. I do think that there is a role for a single gamma knife treatment, whether that be single treatment or 5-fraction treatment for small residual chondrosarc. Personally, I don't think it's really something I would be recommending in chordoma. So getting back to this case from before, and I guess this shows you my approach, I guess, in Brisbane, and there's a range of approaches that are applicable. As I said, dose is dose, it's just how you get it in. I tend to use the guidelines for my first phase, which is treating the preoperative volume with around a 5 millimetre margin, making sure I'm including the whole clivus or anatomical subset, depending on where the location of the primary tumour is. I do a fractionated stereotactic approach up to 60 gray, and then I bring the patient across to the gamma knife, and I do a mask-based treatment where I would then take any gross residual disease or high-risk microscopic disease, to be honest, to a dose as high as I can within the limitations of my brainstem and my optic structures. So routinely, I would do 15 in 5, which biologically for chordoma means I'm getting up above 80 gray. For chondrosarcs, I tend to sit around that 74, 76 gray. So I guess this just shows there's different ways to get the dose in, and certainly over the last, I think, probably 6 or 7 years, my favourite approach has been fractionated stereo with gamma knife boost. In terms of using gamma knife up front, I have to say my results are pretty crap. I've only done it in 2 salvage cases. Obviously, biologically, these have progressed through previous surgeries, in this case 2 surgeries, previous fractionated treatment. I gave a pretty high dose. It held it for a couple of years and then it regrew. So certainly there is some data about this in the salvage setting, but I think when you're getting to salvage, like many situations, you're pushing it uphill. In terms of late sequelae, look, I think you push the dose as hard as you can to the limitations of your optic structures and your brainstem. Using good data now, you should be able to keep the risk of necrosis or vision damage to less than 5%. In terms of pan-hypo-pit, almost all of my chordomas would have pan-hypo-pit longer term because you're treating the whole clivus. Most of a proportion of your chondrosarcs will avoid it. With the pan-hypo-pit, there's no plateau. So your chordomas, if you follow them up long enough, they'll all get pan-hypo-pit. In terms of temporal lobe necrosis, which may result in seizures, I think it's important to differentiate what's a radiologic finding and what's a clinical finding. Radiologically, you probably see it up to 10 to 20% of patients with some enhancement in the medial temporal lobes. What's more significant is whether that translates to seizure activity in patients, and that's certainly less than 5%. In terms of the neurocognitive stuff, there is actually evidence that there is a neurocognitive impact, likewise neurocognitive impact from many of our treatments. But I guess it is the biggest neurocognitive impact for patients is having uncontrolled disease. So in conclusion, I think radiation has been shown to be a mainstay in most cases, excepting that there are some that can be observed. I do feel strongly that they do need to be managed by subspecialist radiation oncologists. Dose is key, many ways to get that in. I've shown you the range of machines. And although protons have some advantages, they're certainly not essential in the management of either skull-based chordoma, chondrosarcoma, or skull-based tumours in general. So thank you.
Thanks very much, Matt. That was excellent. I've just got one question. Timing of adjuvant treatment. Would you say it's similar to a typical post-operative recovery after surgery, that you'd want to get your treatment started pretty quickly? Or is there a role for observation, I guess healing, those sort of things?
I think it would probably come down to a range of factors there, James. I think, I guess grade of tumour. I don't think we do routine Ki-67. It's probably something we probably do need to start looking at. I think the age of patients, younger patients with residual disease, once they've recovered, I would, if there's residual disease, I'd get on and start treating within probably a couple of months, ideally. But look, I don't have a strong sense. There's certainly no data around timing that I'm aware of. I think once they've recovered from their operation, rescan, and then if patients are feeling up to it, then start going down that pathway. Obviously, it's a big haul when you're doing, if you do, irrespective of how you get the treatment in, whether you do photons, all of it, protons, all of it, photons and gamma knife, you're looking at a 7-8 week block of treatment. So it's not a small undertaking for people. What I would say is in the older patients, though, that do require treatment, I'm very comfortable doing it over a shorter period and just treating the gross residual disease, in which case I've done it over 5 or 10 treatments, but getting in that dose up around that 80 gray, but just delivering it punchy in that 5 to 10 treatments.
Okay, well, in the interest of time, I'm just going to quickly check to make sure no one else in the is listening that's got any questions, but I'd obviously like to thank our speakers this evening. We could talk about this for a lot longer, so I very much appreciate you giving up your time this evening to talk to us. Shaan, many thanks. I hope you have a great day. Thanks so much for your contribution. It's really appreciated. Matt, thank you so much. We've all had a busy day today, so I appreciate that. And also to Mitesh and his fellow, thanks so much. Any last comments?